Good morning, everyone. I'm Patricia Houston, and I would like to welcome you again this morning to the International Conference on Stigma. This morning, we have our international session, so I'm going to turn the session over right away to Chris Duncombe, who has been generous enough to moderate, even though he was hit by a storm and has no internet. So he's on his phone right now, but he is still here for us. We're also having a technical difficulty with one of our speakers, so we're going to continue to work on that and hopefully get, I think he just joined. So, okay, we are good to go. Okay, I'll hand it over to you, Chris.
Oh, thanks very much, Patty. Oh, hello, Renato. Yeah, thank you for joining. Yeah, folks, sorry you can't see me because we had a power outage as well, but the power's back on, so that's fine. I just don't have any internet. So last night in Seattle we had a winter cyclone, which I've never heard of before. So we had big winds and snow and stuff. Yeah. So welcome everybody to the international session of the 15th Annual International Conference on Stigma. This session brings together thought leaders, advocates, researchers, and communities with lived experiences to share innovative strategies, cross-cultural insights, and best practices for combating stigma in diverse settings and contexts. We will begin the session with stigma stories, and we'll hear from colleagues in Zimbabwe, Uganda, and Sierra Leone as to how stigma has changed over the years. The video will be followed by two presentations addressing stigma interventions in Peru and Ghana. We will then have time for discussion and Q&A, and Patty will help me with that because I can't sort of see the chat. So please feel free to put your questions and comments in the chat, and we will go through those after the presentations. Please tell us which presenter your comment or question is for. That would be good. You're also welcome to raise your hand during this discussion and make any comments or questions that you have live. So let's begin with stigma stories, and over to colleagues who will start the video. Thanks.
Hello, my name is Gracie from Kampala, Uganda. I can answer question one. How has stigma changed over the years? As far as HIV is concerned, for my case and in my country, people that are infected with HIV right now look amazing. They look so much healthy. They are able to even have families with people that are not infected because there are various ways doctors actually can go about it, and they're able to move on with their lives and their careers, going to work in their offices, sports and all that. And it's something that's just amazing. And also their lifespan is now a bit longer than it was in the years growing up. Because growing up, when you had HIV in my village, people would actually isolate you because of the physical changes on your body, loss of weight, loss of hair. It was just so vivid. There's a certain color that would come on your skin and you'd have these freckles and all that. So people would just, ignore you and all that. So that's how I can explain it. Right now, people look amazing and there's a longer lifespan because of the changes in the medicine, I believe. Yeah, thank you so much.
My name is Idiatu M. Jallo, a sickle cell advocate and a leading founder of Limbic Sickle in Sierra Leone. Sharing my diagnosis as a sickle cell patient has helped me greatly to have a community wherein they will know what to do whenever I have an emergency. I believe that sharing a sickle cell story will help the young ones to also know what to do and how to manage their condition, irrespective of what society says about being a sickle cell. Sickle cell is not a death sentence. When speaking up or communicating about your condition will help you and help others that are around you to know exactly how to treat you and what medication to give you whenever you are having a crisis.
Hi, my name is Emmanuel Otim, a young person living with HIV. Stigma is the reason I'm here to talk to you today about. Over the years, it has been something that has affected many young people or even people older and living with HIV. You are diagnosed with HIV, you just get to learn that you're living with HIV, you face the difficulty with accepting that you're living with HIV because of stigma. But now it has changed. because of the things that we've put in place, including health educations, treatment literacy, and combating of myth. Should you be struggling with stigma, we have vast information available out there. But people like me to show you light that it's possible to live with HIV and overcome stigma. It's possible for you to live a healthy life even with HIV. And stigma shouldn't be the case of these present days even up to now. So yes, it is possible to eradicate stigma and end it. Not like those days, but in the current days. Thank you and I love you all.
I'm talking about yeah, that's just how we love. How we love. That's just how we love. How we love. How we love. Daddy man.
Thanks very much. That was very interesting indeed. Yeah. Paddy, do you want to have Dr. Nyblade go first, or how would you like to run it?
Either way, if you would have switched the order back since Renato's here, that's fine. I think it doesn't matter too much which one goes first.
All right. Renato, can you share your slides for us, please?
Yes, of course. Okay. Can you all see it?
Yeah, perfect. Yeah.
Okay, thank you. Well,
so our first speaker is Dr. Renato Aria. Dr. Aria is a Peruvian physician researcher with over a decade of experience conducting global health research and interventions focused on people affected by HIV. He leads the HIV program at Peru's branch of the non-governmental organization Partners in Health. He focused his global health practice on behavioral research and interventions to facilitate access to comprehensive care to the communities most affected by HIV in the country. These are transgender women, men who have sex with men, migrants and adolescents, including programs and studies targeted at HIV-related stigma. The title of today's presentation is Change Target Messaging and Content Delivery for a Social Media Campaign Addressing HIV Stigma in Peru, a Qualitative Study. Thank you.
Thank you, Chris. Hello, everyone, and good morning, and thank you very much for having me here. Yes, as Chris says, I am a medical doctor based in Peru. I conduct HIV research for some years, and today I'm gonna show you a study that we have been conducting in the past 2 and 3 years, and it is about a social media campaign to decrease HIV stigma in Peru. By the time I submitted this poster, we had only finished with phase 1 of this research, but currently we are in the phase 3. So I'm gonna take the chance to also explain a little bit more, not only about the phase 1, which was the main content of this poster, but also to tell you more about phase 2 and phase 3, so you can have a better idea of the overall research that we have been doing. But the focus of this poster is actually the results of the phase 1, which I am gonna show you now. So in general, as you all know, HIV stigma has several harmful uh, consequences at many levels. So people who are living with HIV and have internalized self-stigma, many of them are not adhere to ART. Many of them have not disclosed their HIV status, and therefore many of them also lost their social support. Also, negative opinions about people living with HIV may also prevent ones from accurately assessing their own HIV risk, and therefore also preclude seeking diagnostic or preventive services. And discrimination about against people living with HIV may also lead to loss of housing, loss of their jobs, and uh, rejection by their friends, family members, and also partners. So Peru is a country in Latin America. It has high levels of stigma among people living with HIV. In a recent study conducted or finished last year in 2023, conducted in several countries of the region, it showed that 50% of people living with HIV in the country reported that they have suffered some form of discrimination in the last 12 years. In Peru, the HIV epidemic is concentrated in already stigmatized communities, such as men who have sex with men, transgender women, migrants, and sex workers. So mitigating stigma is critical, not only to improve individual HIV health or health in general, but also to improve global HIV targets. So having said this, we conducted this study, which objectives are two. First, to create and to address a suite of multimedia content designed to reduce stigma related to HIV, including HIV self-stigma. And secondly, to examine the feasibility of collaborating with influencers to disseminate the content through a social media campaign. And how we did this? We did this through three phases. I'm gonna go rapidly through each of them. And the focus of this presentation is the results of phase one. So the three phases are structured as shown in the slides. So first, we conducted qualitative research. Then through the qualitative research, we prepared the content of the campaign. And then in the phase three, we implement the campaign and also are currently addressing or examining the results of the campaign through different ways. So for the phase one, which is the phase where we conducted the qualitative research, we conducted 13 focus groups and 16 in-depth interviews with the goal to answer two main questions. The first question is, what would the participants or what would people like to change as a result of a social media campaign directed to adolescents? And the second the second question, what messages are important to achieve those changes? So in this phase, overall, we included or we interviewed 110 participants, and they were very diverse in their identities and their characteristics. We included young people living with HIV who acquired HIV perinatally, but we also included young people newly diagnosed with HIV, and this included gay, bisexual men and other men who have sex with men, transgender women, persons who engage in transactional sex, cisgender women, and Venezuelan migrants, which are currently there's a big migration phenomenon occurring in the country. And besides the youth living with HIV that we included, we also interviewed healthcare personnel and HIV activists, and most of the HIV activists were also young people. So the results of this phase one are mainly two. We divided them first in the change targets and the key messages needed to achieve those change targets. So we identify two change targets. The first of it is the need to change the perception of HIV and the perception of people living with HIV. And to achieve this, we identify three main messages. The first of it is is the message that that HIV does not discriminate, and this basically means that HIV can occur to anyone. HIV is not a condition affecting a particular community or particular groups. HIV doesn't discriminate, and it doesn't matter if you are gay, if you are it doesn't matter your sex, your identity, your social status, or what you do for your life. Basically, anyone can acquire HIV. The second message is that HIV is a treatable chronic condition, and compared to many years ago, many years ago, when HIV was a death sentence, nowadays we all know that HIV it is not, and that it is very treatable, and and you can live you can have a very good quality of life living with HIV. And the third message is a more modern message, and it is the concept of undetectable equals untransmittable, U equals U. And as it is mentioned in the quote, some people still are some people doesn't necessarily trust 100% of this, or doesn't necessarily believe that it's true. As it is said in the quote, some people think that there is a bad, that there is a bad, and that there is still a risk of transmitting HIV. So as you can see, to achieve this first change target, the messages are, or the key goal is mainly to inform about these three main messages that for some people it is still unknown. So the goal of this first change target is basically to educate about HIV. However, the second change target is goes more from educating to actually taking action. So this change target tell us about the goal is to change the attitudes and the behavior towards people living with HIV. And for this, we identify four main messages. The first message is to normalize talking openly about HIV. We're never gonna actually end up the taboo or the stigma about of talking of HIV if we do not talk openly about it. The second message that participant agreed is that they want support and not pity. As it is said in the quote, they don't want people to say they don't want people to feel bad about them. They don't want people to feel sad about them. They just want to have the support as anyone with a medical condition would have, because we all know that HIV here is just another chronic medical condition. And the third message is to promote inclusion, and this message was very related to promote inclusion, especially in their jobs. We here in Peru, and I guess that in many other countries too, there is still discrimination for hiring people that are living with HIV. Some jobs still request an obligatory HIV test for their application interviews. And also when you are already hired and your HIV status gets disclosed intentionally or not. In some jobs they also fire people living with HIV when they get to know that they are living with HIV. And the fourth message is to foster unity across the affected communities of HIV, which in Peru are mainly the LGBTQ community. Um, and this community was very open, and they all agree that there is also discrimination within the members of the community. Just an example, there is many times discrimination between from gay men to transgender women. So they all agree that this discrimination, this stigma within the people who are living with HIV should also decrease, or should also end, if they want to all be unite to fight against HIV stigma. And there were also recommendations on how the content of this social media content should be delivered, and the recommendations were about the how, by whom, and to whom it should be done. Regarding the how, they recommended the use of videos, the use of short videos, 15 to 30-second videos. They also talk about some images. For example, the use of the red ribbon in the campaign was very controversial. They also mentioned to use with caution the LGBTQI plus flag, because it can produce the contrary effect of stigmatizing the the LGBTQ plus community. In terms of the whom, they were very clear to mention that the content, the videos, and the people who are transmitting the messages and who appear in the videos should be from diverse identities, including these different genders, sexual or or orientation, races, etc. And they also said that it would be more credible is if people living with HIV are the characters over actors who in reality don't live with HIV.
Renato, are you there? I think you've frozen. Yeah.
Oh, I can try to email him. Maybe we have to shift. Oh, there. Looks like he's trying to sign out and back in.
Okay, let's just wait a minute. Yeah.
So sorry, I think I lost my internet connection, but I am back.
Yeah, thank you. Great.
Okay. Okay, I think this is where I left the session. So those were the findings from phase 1. The phase two is where we collected or where we analyzed all the data from the qualitative interviews, and we started to create the content. So to create the content, we create the content through two ways. The first, we hired a content creation agency, and then we also recruited influencers who also created their own content. This phase two was actually very challenging, but at the same time very interesting because there were several videos, several approvals that we needed to do in order to get the final validated video. The phase three is comprised of four subphases. Phase 3A is actually the delivery of the campaign itself. The campaign itself was delivered through two social media platforms, TikTok and Instagram. The campaign lasted 3 to 4 months. It was very interesting how different videos were more, let's say, viral or more impactful than others in between the platforms. So one of them were more impactful in TikTok, and others were more impactful in Instagram. And the reactions and the public that also see the videos or that use both platforms are different. So the style also need to change in order to get the attentions of the users. Now we are conducting these three subphases where we are evaluating in different ways the campaign. I mainly want to focus in the one in the middle, which is the phase 3C. For this phase, we conducted a randomized study. So we enrolled people living with HIV between 18 to 29 years before the initiation of the campaign, and we randomized them to either be exposed to the campaign or be exposed to another Instagram and TikTok account that didn't have anything to do with HIV stigma. And then after the 3 or 4 months of the campaign, we are contacting them again to measure the same HIV stigma questionnaire that we use at baseline to see if there are changes between the control group and the group that was exposed to the campaign. This is one way on how we are going to measure the impact on HIV self-stigma on people living with HIV. But then we also have some other ways to measure specifically the content. We are selecting 4 or 5 in phase 3B. We are selecting 4 or 5 videos, top videos, to see and expose them to youth in general. Some of them are living with HIV and some of them are not. And we are measuring the pre and post score in another different HIV stigma scale to see if those particular top videos also had an impact on the HIV stigma score. And then in phase 3D, we are not here yet. We are gonna have focus groups and interviews with the participants and with the influencer who also support this campaign. So as conclusion, the results of phase 1 tell us that a social media HIV anti-stigma campaign should address both the perception of and attitudes towards people living with HIV and HIV, and should also consider how, by whom, and to whom the messages are directed. We believe that this study helps to move HIV-related stigma research from descriptive to interventional. And while this study is exclusive to Peru and may not necessarily represent the context of HIV in other parts of the world, we believe that its final findings will likely have broad applicability in some Latin American countries, expanding the evidence base regarding the use of social media to reduce HIV-related stigma and to potentially other stigmatized conditions. And thank you very much, all of you, for listening to me, and also thank you very much to all the team from Harvard Medical School and from the University of South Florida for making this study possible. Thank you very much.
Thanks very much, Renato. I think let's hold questions and comments until the end, and we'll move on to our next speaker.
Okay.
So our next speaker is Dr. Laura Nyblade. Dr. Nyblade is a fellow and senior technical advisor on stigma and discrimination in the Global Health Division of the International Development Group, RTI International, working in close collaboration with researchers, civil society and governments across sub-Saharan Africa, South and Southeast Asia and the Caribbean. She has led the design, rollout and evaluation of evidence-based HIV stigma reduction programs, the development of programmatic tools to engage multiple audiences, and the development and validation of stigma measures. Today, Dr. Nyblade will speak about addressing intersectional health facility stigma and intervention approach from Ghana. Thank you.
Thank you very much. Can you see my slides?
Not yet.
No? Okay, that's odd. I am sharing. Don't know what's happened.
Okay,
Yeah.
wait, here comes something.
You can see, but I can't see.
No, it turned black. Hold on.
Let
me
me
fix
stop.
what's
Let me
on.
stop sharing. Let me stop sharing and I'll try again.
Okay.
Sorry about that. They were working earlier when we tested them.
They were, yes. Take your time.
Okay, let me try again. Let's see if hopefully second time will be the charm.
Yep.
Okay, there it is.
Okay, so let me get it on slideshow. How's
Good to go. Good to go.
Oh, okay. One can never have anything without a little bit of drama, right?
Yes.
So good morning, good afternoon, good evening, wherever you are in the world. Thank you for joining us this morning, and thank you to Howard University for inviting me to present. It's such an honor to be here. I didn't realize it has been 15 years of this conference. I remember the first one. So it's truly an honor to be back here and to be able to share some collective work with you. I'm here presenting on behalf of a very large team. This study was co-led. I co-led this study with Dr. LaRon Nelson from Yale. And so, yes, I'm very honored to be able to share this collective work with you. Before I get started, I just want to mention a little bit of about who is behind this work. So these are our partners in Ghana, and as well as in the US and Canada. This work was done under funding from the US National Institute of Nursing Research at NIH. And we also had government partners in Ghana. So I'm going to jump right in and talk a little bit about our study design. As the title mentioned, this is a multi-level study. So we are implementing interventions we're done with the study at the health facility level, which is what I'm going to talk about today, which is the part of the study that I led. And then we also had interventions at the interpersonal level, so within communities of men, and then also at the individual level, which was a peer mentorship intervention. I'm not going to talk about those two levels because I don't have the time to talk about everything. So I'm just going to focus on the health facility. But the idea behind the multi-level intervention is that we know stigma occurs at all levels and all facets of our lives. And so to really effectively respond to stigma, we also need to be responding at multiple levels. So we put these 3 levels together. We in Ghana have had individual level interventions at each of these levels that were shown to be successful. So we had a process of combining them, so bringing them together to reduce intersectional stigma at the health facility, create supportive climate for men who have sex with men in Ghana, and at the individual and community level to also reduce intersectional stigma and also increase testing and motivation and skills for HIV testing. At the time, there was no PrEP available in Ghana, and we were responding to a call for proposals that was about prevention. So our main outcome was HIV testing. So our goal was really through this multi-level intervention to increase the frequency of HIV testing among men who have sex with men. And that is the term that the community asks us to use in Ghana at the time. That's changed since, but that is in the title of our grant. So we had a randomized, we started with formative research, which informed the adaptation of the 3 interventions and their combination. And I'll talk a little bit about what we did in the adaptation. And that so we conducted formative research, focus groups, in-depth interviews, both with men from the community and also with healthcare workers. And that informed the adaptation, which then led into this randomized controlled trial phase, where we randomized health facilities and participants. And then we started with the healthcare facility intervention because we wanted to, in our treatment and facilities, to destigmatize them as much as possible before asking participants to actually go to those facilities. All the facilities and all the men eventually got the interventions because it was a waitlist design. And so I'm just going to, because the time is brief, I'm just going to share some selected results. And by results, I mean both sort of explaining the health level intervention, as well as just a kind of high level, like what happened with it. So the intervention that we adapted to address this intersectional stigma in healthcare facilities was something called the Health Policy Plus Total Facility Approach for HIV Stigma. And this is an intervention that was adapted and developed in Ghana and also Tanzania, and it's being used around the world, and it has been very successful. It's also the basis for a national program in Thailand, but it builds on evidence from 2 decades of research and programmatic work. It recognizes that all health facility staff have a role to play in stigma reduction. Stigma doesn't just happen in the clinical encounter. It happens at the gate. It happens at the reception. It happens when you're walking through the hallways and you're interacting with other people who work in the healthcare facility. And so this approach really recognizes that all staff have a role to play in creating that environment and reducing stigma, that environment we want. That provides respectful care. It's also very much grounded in principles of participation, and we work very hard to provide health facilities with the knowledge and skills to actually develop their own stigma reduction activities and processes. So I'll talk a little bit about what that looks like in a minute. So when we did the intervention adaptation itself, so when we were adapting from the HP plus, the HIV, which was focused on HIV stigma reduction, to address the intersection of HIV, same-sex, and gender nonconformity, there are a few things that happened. So we were informed by our formative work, and then we went into kind of a workshop process with clients the men who go to health facilities as well as healthcare workers, to really look at what did that mean for what needed to be adapted in the HP Plus. So a couple things that happened. One was that we expanded the existing participatory exercises, because this is all a participatory approach, to incorporate a deeper understanding of men who have sex with men and gender nonconformity stigma content. And we did that by adapting and creating new pictures. We have an exercise where we use pictures to start a discussion around stigma, what it looks like, how it's happening in healthcare facilities, what it does. And then also developing new case studies and role plays that are part of the other exercises in the first part of the intervention, which is a participatory stigma reduction training for all staff in the health facility. We also created 2 completely new exercises to address gender and misconceptions around mental health and men who have sex with men. And those are called Outside the Gender Box and How Myths About Men and Mental Illness Can Lead to Stigma. So, and then we incorporated specific stigma manifestations that came out in the formative work into the actual existing exercises. So, for example, the one I just mentioned where we look at pictures and we named stigma through pictures. We have an exercise around confidentiality, which is a big issue that came out in the formative work, and also around gender and sexual diversity. So just to give you an idea, the HP Plus is a very adaptable approach and that's sort of why it's being used in many countries, but to give you an idea of how it gets adapted. So how do we actually implement the healthcare facility level intervention? So it has 3 pieces. The first is a training of trainers. So we train healthcare workers and clients, in this case, men who have sex with men, to actually deliver the training. So we have master trainers who are based in Zambia, who came to Ghana and worked with some of our master trainers in Ghana as well to deliver this training. So healthcare workers from the facilities that are receiving the intervention are trained alongside clients, but not necessarily clients from their health facility, but clients from the area who are comfortable doing this, are trained then to actually deliver the intervention in the healthcare facility. So we've learned over the years, this is very important, that the training on stigma is coming from within the facility, not from external. So then once this training happens, then we have what's called a facility step down training. So these trainers, these training teams then go and deliver the training within their facility. And the training is 20 to 25 health workers in a group. It's about 10 to 14 hours. I'll show you in a little bit what it is. It's modular, so it's very flexible. You can deliver it depending on how it works in the facility, either in 2 to 3 hour bunches over any period of time, or a single, 2 single days or 2 consecutive days. Different facilities have delivered it in different ways, depending on what works in their facility setting. And then after everyone's been trained, we have this, we call them champion teams or champion groups. So what happens during the training is people kind of bubble up within the healthcare facility who want to do more around stigma reduction. And so this is a group that management formally puts together and sanctions as a formal group in the health facility, and they work to do different kinds of stigma reduction interventions. And we give them a very small seed grant, but they're really looking for things to do to institutionalize stigma reduction in how services are delivered that doesn't cost anything. So that's the activity. And this is what the training curriculum looked like. And basically it's focused on addressing what we call the actionable drivers of stigma in healthcare facilities, the immediately actionable drivers. So the things that we can change now as we work for that longer social change. And these things, these actionable drivers really do lead to change pretty quickly. And one is just creating awareness of what stigma does, what it is. So most of us are stigmatizing on a daily basis and aren't aware that we're doing it. So something as simple as creating awareness of what stigma looks like in concrete terms, and what we do, what we say, how we interact with people can create a big change. Most health workers don't intend to stigmatize. They don't know that they're doing it. And so you can create a lot of change quickly just by creating awareness. One is understanding the fear of contracting HIV in the workplace. That might sound surprising, and that health workers are still afraid of contracting HIV in ways that HIV can't be contracted. But unfortunately, it's still a reality in most of our healthcare facilities around the globe, not just in Ghana. And so it's important to address that. Confidentiality, our beliefs, our values, how they show up in the way we deliver services. And then we always have a session at the end that's really around, okay, what are we going to do about this now? So working to create change. Some of the activities that hospitals have come up with, all of them have wanted to publicly signal that they have changed. And so some of the small seed grant money that we gave them, they used to develop really large banners that went up around the hospital around what they are proud to say they have changed. And these also came with accountability mechanisms. So they came with numbers to call if we're not actually doing what we pledged to do. So just to say we evaluated it, I won't spend a lot of time here. I know we want to have some time for questions. So just to say we had 3 cross-sectional surveys and we had systematic sampling. We had a lot of exposure to the interventions. You can see the kind of blue ones are the intervention, and then the control are the hospitals that they eventually got the intervention. But you can see there was some stigma reduction work going on at those hospitals. Just to give you a sense, though, that we did succeed in reaching a lot of the people with this intervention. We measured and validated a scale. This is published now on intersectional stigma. So this is the scale that when I show you the next results, I'm going to use. It has 3 subscales. One is comfort with intersectional identities in the workplace. So working alongside people who have different identities. Beliefs about gender and sexuality norms, and beliefs about people living with HIV. So these are the 3 subscales. So here are the results real quickly. So I guess, I don't know, I guess it would be on your left of your screen is the total score. So the total score for this measure. And you can see that the intervention is the red line and the control is the blue line. And you will notice that we had some difference, but it's not huge between, it looks huge on this graph because of the way the graph is broken up between the control and the treatment at baseline. But what you'll notice is that at 3 months, we had a significant impact on this overall stigma score between the control and treatment arm. And that actually, that changed a bit at 6 months, but it was still relatively significant. And then if you look at the second graph, which I want to pull out because this is really what we were focused on in our intervention, which was the sort of stigma around gender and sexuality. And oops, I guess I don't have nice red slide boxes on this, but as you'll see, again, it's the same pattern where we had a significant effect at 3 months. And actually with the gender and sexuality stigma, we actually increased, the effect actually increased at 6 months. So these additional activities that we were doing after the training seem to have really helped solidify this piece of it. I also want to just share quickly that, as I mentioned, one of the key drivers in a lot of places in health facilities around the world is this continued fear among healthcare workers that they will contract HIV by providing services to clients who are living with HIV. So we spend time in our intervention really trying to address that fear. And so I just wanted to show you of an index that that measures HIV worry. And so you can see that we had quite a bit of worry, but we were able to very successfully address that worry. Again, the red line is our intervention and the blue line is our control. So you can see this is a very significant difference at 3 and at 6 months. So again, those additional activities after the training seem to be helping to maintain the effect of the intervention. So that's what happened among the healthcare facility staff. And you might say, okay, so great. Does that do anything for the clients themselves? And so I'm just going to share one slide, which is to show that at 3 months post the health facility intervention, the men who had visited a health facility that received the intersectional stigma reduction intervention had a 5 times higher odds of reporting an HIV test in the previous 3 months compared to men attending non-intervention facilities. And while at 6 months, that increased to 10 times higher odds of reporting an HIV test in the previous 6 months. So it's, so we were successful in reducing stigma and intersectional stigma in the healthcare facilities, and also and see that resulting in men testing for HIV more. So just in conclusion, the intervention was effective, as I've just shown you, at 3 and 6 months post-intervention. The men attending the intervention facilities were significantly more likely to be tested for HIV compared to men who were going to non-intervention facilities. The HP plus total facility approach was very adaptable to this intersectional stigma. And I just want to say, even in a challenging social, political, and legal climate around gender and sexual diversity, most health workers welcomed the intervention and were eager to learn and improve their services. So just to say, even in that kind of in this climate of in Ghana, where it, there's a pretty there's a bill in front of the parliament that's pretty challenging. The study demonstrates that we can still do something at the healthcare facility level to address this intersectional stigma faced by gay, bisexual, and other men who have sex with men. So thank you.
Thanks very much, Laura. Yeah, and stigma and discrimination are still such an important barrier to accessing care, I think, in so many countries. And it's, I think you're right that you can work at the clinic level and at the hospital level, even though higher up in society and in government, there may still be significant challenges, as you say. Yeah. So let's hand it over for discussion and question and answer. And Patty, can you help me a little bit?
Yeah, sure. So I'm looking in the webinar chat and I don't see any questions yet. I see somebody said, thank you very much. I'm just checking because there's that other sort of chat in Whova. Let me just text my coworker.
Patty, there is a question from Elisa, and she asks Dr. Rea, how were you able to control exposure of the DIME content for your control group?
Yeah, thank you, Lisa. That's a very good question. I also answered, someone else also asked that before, and I answered it directly, but I was about to answer it to Elisa. But so that's a very good question. As it is social media, we were actually not able to control the exposure to the social media campaign, but what I can say is that at the time of enrollment, we only share the TikTok and the Instagram accounts to the participants from the intervention arm. So those from the control arms did not know about our accounts. These accounts were very new. They started with less than 100 followers. So that might have helped, at least in the short time that the campaign lasts. That might have helped in the terms that probably the campaign, probably as it is not a very popular, as they were not popular accounts, the algorithm of Instagram and TikTok might not necessarily show them the accounts. So we believe that might have helped. That was less true, honestly, at the end of the campaign, or at least now that we are 4 to 5 months after the initiation of the campaign. We now have more than 10K followers in one of the accounts. But we are also collecting in the post-campaign questionnaires. We are also collecting if they saw our accounts in any time within these 3 and 4 months. So we are gonna analyze if those in the control arm were actually exposed to the campaign or not. But you are very right. As it is a social media campaign, at least we did not find or did not know a way on how to control that.
Okay, thank you. Let me see. Somebody is showing me.
I see a question in the webinar chat about how do you reduce the fear from healthcare workers from contracting HIV if they don't know how HIV is transmitted. So I can take that one if you like, Patty.
Oh, sure.
Yeah.
Yes.
So yeah, thank you for that question. So we have so our training, it's through training, and it's part of our participatory training for reducing stigma. We're really focusing on what we call these immediately actionable drivers of stigma, and fear is one of them. So we actually have a exercise that's participatory in nature, and we call it QQR, which is quantity, quality, and route of transmission. And part of what we've learned over the past 20 years is that most healthcare workers, if you ask them a standard CAP survey, knowledge awareness practice survey, they can tell you, HIV is transmitted this, and this way, or it's not transmitted this way and this way, but they don't actually believe it. And there's some really very deep-rooted fears. So this process that we go through, it's like an hour process of training, is really trying to address the specific fears. So what is it they're afraid of? So for example, we learned that especially with the advent of testing, HIV testing through saliva, sort of fear of saliva became for some people is very, very much like you can get HIV through saliva. So we address that head on. So we try to learn what is the specific, understand how the fear is coming about and what it's in, like what body fluid is it in, or what is it that they're afraid of, and then address that head on. And that brought us to this QQR, quantity, quality, route of transmission. It's very kind of basic, probably we talk about, you have to have a quality virus to be able to transmit it. You have to have quantity, and you have to have a route of transmission into the body. And then we're very graphic about sort of like, well, how much HIV is there in saliva and spit? Like how much spit would you actually have to ingest to get enough, quantity or quality of virus? Like you can't transmit it that way, but it's really trying in a very visceral way to get people to grapple with their fears and understand why the fears are not rational. We also have to acknowledge that in a lot of places, people don't have the PPE, the protective gear that they need to actually protect themselves in situations where there is some risk. So for example, when you're delivering a baby, I had one doctor pull me aside in one place and say to me, yeah, I test my clients if I suspect they have HIV without them knowing, because I don't have enough gloves in my facility to deliver every baby with gloves on. So we do have to, do that in the reality of the setting. And then we help people understand how it's transmitted and not transmitted. And the U equals U is part of that as well. I will tell you, a lot of healthcare workers do not actually quite believe U equals U. So that's another piece, I think, with our stigma reduction that we really need to work on is communicating the science around U equals U. So it's yeah, that's and then we actually have the people in the training practice. We have, like, we call them our goalless wheel, where health workers, you have one wheel in the middle and one on the outside, and then basically you go around and practice actually explaining to someone else in the training how HIV is transmitted or not, etc. So Marcel.
All right. Thank you, Laura.
Okay, and I know we're out of time. I can't actually tell you that. We can't actually.
Out of time now. So, Chris, do you have any closing words?
Yeah, thanks. Thanks everybody for putting for me just being on my phone. No, I'd just like to thank both of our speakers, Renato and Laura, for a really interesting presentation, and thank you to the people who put together the videos. I think it was a very good session. I saw we have more than 80 people online, so people are interested in this. And thank you to Howard University for inviting me to chair the session, and I look forward to chairing it again. And I hope my internet comes back soon. So thanks everybody. Have a good rest of your day.
Thank you. And next session is the plenary, so join us in the virtual plenary momentarily. Thank you.
Thank you.
Bye-bye.
Bye.